All right, well, welcome back, everybody. Hope you enjoyed your break. We're going to go on to our next topic, which is current treatment options. And I think this disclosure is an important one because I'm going to be speaking about current therapies as well as emerging therapies. And as you will see from my disclosure, I have consulted for several of the companies that manufacture these products. So please keep this in mind as we go through this next series of slides. So our learning objective. We want to apply information on new and emerging therapies into the development of individualized management strategies for patients with MS. This is a bit of a lofty goal, but we're going to go ahead and give it a try. We're going to discuss the mechanisms of action of existing and emerging MS therapies, review the clinical data supporting efficacy, and review known and potential adverse events associated with these treatments. So here is our current and emerging landscape for MS therapies. As you can see, there are multiple therapies illustrated on a timeline here, with the first therapy approved for treatment back in 1993, became really commercially available in 1994. That was interferon beta-1b. A couple years after that, in 1996, a formulation of interferon beta-1a became available, as well as Glatiramer acetate. A little after that, a medication called mitoxantrone, now not used very often for MS therapy, a chemotherapeutic agent, became approved in 2000. And then in 2002, interferon beta-1a thrice weekly was approved. And then in 2006, Natalizumab was reintroduced. A little bit later, another version of interferon beta-1b came onto market, and then we had approval of the first oral treatment for MS, Fingolimod, and then most recently we've had two other agents, just one approved last year and the other this week, Teriflunomide approved last year, and dimethyl fumarate approved just a couple days ago. And you can see that there's actually a very rich pipeline in development as well, with other oral therapies which include Laquinimod and Ono 4641, and a more selective S1P1 receptor modulator, and then several monoclonal antibodies that are either depleting or immune modulating. And we'll talk about some of these more as we go through the presentation. So it's a very rich landscape, and what's remarkable to me is that we have multiple mechanisms of action associated with these therapies. So it's a very, very exciting time in MS, and we are moving away from auto-injectable therapies into an era of oral immune treatments. Now, one of the things that you'll notice as I go through some of the efficacy slides is that you'll see that the relapse rates in patients seem to change over time. And in the earlier clinical trials in MS, we had higher relapse rates for our patients. And in more recent trials, you'll see that the relapse rates, even in the placebo arms, seem to have gone down. This is a general observation which holds fairly true for MS clinical trials done not only in the U.S. but outside the U.S. And I think it reflects a couple things. It tells us that patients who are participating in trials have lower levels of disease activity, and this may be the patient's decisions in terms of what they're going to do, as well as clinicians' decisions in terms of what they're going to do. We do see that in general this trend has occurred. It also may reflect something inherent within MS patients as well. It may be that the disease itself, although becoming increasingly prevalent, may be less severe. So when we think about our clinical goals for therapy, we want to reduce the frequency of relapses, we want to slow the accumulation of neurological impairment, and we want to prevent morbidity from MS-related symptoms and provide palliative care. We want to ultimately improve patients' quality of life and minimize treatment side effects. And so sort of the perfect treatment is really going to be able to do all of these things. And as you'll see, we don't have a perfect treatment yet for MS, and there's plenty of room for progress to be made. So when we think about our therapeutic approaches, there are multiple strategies. You heard earlier from Dr. Fox about lymphocyte trafficking into the central nervous system. A whole variety of different types of cells of the immune system are involved in MS. And so we have several strategies based on our evolving understanding of MS pathogenesis about how we might address and treat the disease. One approach might be to control lymphocyte trafficking. Another would be to modify the immune system by acting anti-inflammatory immune cells or downregulating pro-inflammatory cells. We could also try a strategy of sequestering immune cells. And we can also suppress the immune system and maybe even protect the nervous system through antioxidative mechanisms. And we'll talk about how current therapies can do each of these different things. So in terms of the immune pathways, there are a lot of different cells that are activated in the periphery. You heard about some of these cells earlier. There are T cells, there are B cells and natural killer cells, as well as macrophages. And all of these cells are able to gain access to the central nervous system where they become reactivated and have a variety of negative effects. Now, what this slide shows you is potential sites of action of various medications in MS. So if we just begin up at the lymph node, you can see that one of the effects of Fingolimod, indicated here by its code letters FDY720, is to suppress the ability of lymphocytes that have been activated from leaving the lymph node and entering peripheral circulation. So this is a lymphocyte sequestering effect. A little bit next to that, you can see that that group of rapidly proliferating T lymphocytes are inhibited by medications such as cladribine and teriflunomide. Some of those cells trying to get into the central nervous system are blocked from doing so by one of our monoclonal antibodies, Natalizumab. We know that a type of natural killer cell which suppresses T cell function, the NK56 bright cell, is activated by Diclizumab, a MS therapy in development. And we know that anti-B cell therapies that knock out cells that are producing antibodies and presenting antigen, rituximab is illustrated here, but other medications that are in development, such as ocrelizumab, do the same thing. They may have important effects in multiple sclerosis as well. We think that there are a couple of interesting compounds that are able to have potential effects within the central nervous system that are anti-degenerative, and they include medications like Laquinimod and fumaric acid, dimethyl fumarate, and possibly even there may be neuroprotective effects for Fingolimod as well. And another strategy is to ablate cells of the immune system and allow them to repopulate and see if you get now less autoreactive T cells, and that strategy is with Alemtuzumab. So you can see a lot of the basic understanding of immune pathology in MS has driven development of a variety of therapies that are either currently approved or in development for MS. Now, I'll just briefly mention some of these strategies to you. Interferon, of course, has been our mainstay of therapy for many, many years. And interferon has potent effects at the blood-brain barrier, illustrated in the middle of this slide. We know this because we see a dramatic reduction in contrast enhancement following interferon beta treatment. Interferon beta induces a whole variety of genes within peripheral blood mononuclear cells, including T cells, and induces perhaps a shift of the Th1 to Th2 bias, reduces the production of matrix metalloproteinases, an important enzyme necessary for these lymphocytes gaining egress within the central nervous system. So we know from trials with interferon beta, and this is just a couple examples here, that there is a significant reduction in the annualized relapse rate with interferon beta treatment. You can see the PRISMS trial and another trial illustrated on this slide. The bar graphs simply reflect the 2-year annualized relapse rate with placebo and the active treatment groups, and you can see that the number of relapses does come down. Now, in terms of adverse events, of course, interferons have a number of well-documented adverse events. These include flu-like symptoms, injection site reactions, laboratory abnormalities. One should monitor patients for liver function tests. There can also be white blood cell abnormalities as well as decreases in platelets. Depression has been associated with interferon treatment, And interferons can develop neutralizing antibodies that have the potential to abrogate their therapeutic response. And as is the case for most of the MS treatments, these are pregnancy class C. Now, glitiramer acetate has been widely used and is now one of the most popular therapies in MS treatment currently. The mechanisms of action of GA were not immediately clear. It seems that there are now pleiotropic effects of GA on the immune system. You can see there's an effect on antigen presentation, downregulating the ability of antigen-presenting cells in the periphery to present antigen to T cells. There are effects even on B cells of glitiramer acetate that regulate B cell function. We think that glitiramer acetate also helps induce a Th1 to Th2 bias shift. It certainly does so in EAE animal models. Less clear if it does that directly within humans. And there's also a concept that glitiramer acetate treated T cells, ones that have had a chance to respond to glitiramer acetate, are able to cross the blood-brain barrier and there have an effect within the central nervous system, suppressing other inflammatory cells through a mechanism called bystander suppression. They may also secrete factors that may be neurotrophic, such as BDNF. So there are multiple places within the immune network that GA may work or has been proposed to work, but exactly which, if not all of these processes, has yet to be clearly demonstrated as the clear mechanism of action in MS patients. Now, we know that glitiramer acetate is also on its own, compared to placebo, effective at reducing the annualized relapse frequency. Recently, we have seen multiple head-to-head clinical trials now very clearly demonstrating that glitiramer acetate and high-dose, high-frequency interferons have very similar clinical efficacy. And results of the REGARD trial here on your left and the BEYOND study on your right show that the impact comparing glitiramer acetate to two different formulations of high-dose, high-frequency interferon is very much the same. We also have data indicating that high-dose, high-frequency interferon may be a little bit better than once-weekly interferon, and now with the CombiRx data, also an indication that glitiramer acetate may be superior, albeit to a limited extent, to interferon beta-1a once weekly. So the main side effects of glitiramer acetate, of course, are injection site reactions, and in about 10% of individuals they will experience systemic reactions, which include a post-injection systemic reaction that can be associated with chest tightness, tachycardia, flushing, shortness of breath, and patients often wind up in the emergency department with this or evaluated for an MI. They do not have an MI. These can come in out of the blue. They can occur once or can occur multiple times in the same patient. Out of all the various medications that are currently approved for MS, this is the only one that has a pregnancy class B category. No treatment has a pregnancy class A category, meaning known to be safe in pregnancy. This one, though, with the class B, there at least are some supporting observational studies indicating that women treated with glitiramer acetate through their pregnancy don't have a disproportionately larger number of birth defects or spontaneous abortions. Now, natalizumab has a very selective mechanism of action. It's a monoclonal antibody and therefore binds to a single target. In this case, it is binding to VLA4, which is expressed on lymphocytes, and basically by it binding to VLA4 blocks the ability of VLA4 expressed on lymphocytes and monocytes from interacting with another molecule called vascular cell adhesion molecule. And what you can see on this slide is vascular cell adhesion molecule being expressed on endothelial cells, interacting with VLA4 in the top portion of the slide, allowing those lymphocytes to adhere to the blood vessel wall and thereby initiate the process of migration into the central nervous system. So for those lymphocytes that seem to be associated with CNS injury in MS, this first step of those lymphocytes binding to the vascular wall and initiating that migration step is crucial for those lymphocytes to get into the CNS. By creating an antibody against VLA4, we don't deplete the lymphocytes. We don't wipe out the lymphocytes. They're still there, but their ability to interact with VCAM is now blocked. And this is the basic mechanism of action of natalizumab, illustrated in the lower half of the slide. So instead of those lymphocytes and monocytes adhering to the vascular wall, they roll on by and continue through the circulation. Here are some of the efficacy results for natalizumab. The reduction in the annualized relapse rate in the AFFIRM trial was 68% over the 2 years of that study. There was a 42% reduction in disability using the 3-month EDSS sustained change measure and a 54% reduction using the 6-month sustained change measure. Patients also had substantial reductions in the number of new T2 lesions on MRI at year 2 by 86% and 92% reduction in the number of contrast-enhancing lesions relative to placebo. So a very efficacious drug. Now, there are some very important adverse events. Patients can experience an allergic reaction to the medication. This is relatively rare, happens in about 1% of patients. But as you are all familiar with, I am sure, the drug has been associated with a rare opportunistic infection called PML. And PML is caused by the JC virus. This virus is present in about half of the people in this room. Normally it just stays within your kidneys, doesn't do much, goes along for the ride. But in the setting of immune compromise, the virus can become activated, can move through the blood into the brain, get into the brain, and cause progressive multifocal leukoencephalopathy, a rare and unfortunately often fatal brain virus infection. When it is not fatal, it often is also associated with significant disability. The drug can also cause hepatotoxicity. There are neutralizing antibodies that can abrogate its efficacy, and as with most of the other compounds, is pregnancy class C. Now, the next medication I'm going to mention is Fingolimod. Fingolimod is a sphingosine 1-phosphate receptor modulator. The mechanism of action of this drug is to cause lymphocyte sequestration within lymph nodes. The S1P1 receptor is normally expressed on the surface of lymphocytes, and when activated, allows lymphocytes to leave lymph nodes. So the lymphocyte stays within the lymph node. Through activation of the S1P1 receptor, those lymphocytes now can leave the lymph nodes, join the circulation, and eventually get into the brain and spinal cord. By modulating the S1P receptor, Fingolimod causes internalization of this receptor and thereby sequesters lymphocytes within lymph nodes. The basic concept here is keeping the bad guys in jail. So, and this medication also has been proven to be effective across 3 large phase 3 clinical trials. Some of the data from the Transforms and Freedom study is summarized here. But you have a reduction in annualized relapse rate across these 3 different trials by about 50%. In the case of the Transform study, this was a head-to-head comparative study versus interferon beta-1a. And for the Freedoms 1 and Freedom 2 trials, there was a comparison versus placebo. There was also significant impacts in terms of disability in the Freedoms 1 study and impacts in terms of brain volume loss, which were consistent across all 3 trials, as well as impacts in the number of new T2 lesions and contrast-enhancing lesions. So a very efficacious medication. We also have some limited data in terms of long-term follow-up with some of the patients who had participated in the phase 2 study now having been followed over 8 years. Now, in terms of adverse events, what's well known about this, by direct action of S1P1 receptors at the sinoatrial node, an effect which is essentially simulating that vagus nerve stimulation, we do see some bradycardia with the first dose. This bradycardic effect typically resolves by about 1 month after treatment and really actually resolves quite quickly, often within the first few hours of administration of the medication. But it has been associated with cardiac conduction block, and for this reason patients need to be monitored with an EKG before they go on to treatment, as well as an EKG 6 hours after the first dose. And if we see any evidence of conduction block that may be a significant conduction block, we have to admit those patients overnight for further observation. The drug can be associated with hypertension. Liver function abnormalities are relatively common with this medication, but rarely does the medication need to be discontinued because of LFT increases. The drug can also cause swelling of the seeing part of the eye, macular edema that can be associated with loss of vision or diminished vision, often resolves following discontinuation of treatment and is primarily associated with patients who have either pre-existing macular edema or a history of type 1 or 2 diabetes or uveitis. The drug can also cause herpes virus reactivation, and in particular, we have to screen for patients for VZV. We want to make sure that patients are either have a history of VZV or have been immunized so that de novo infection cannot occur. De novo infection was associated with 1 death in the clinical trial due to widespread zoster or disseminated zoster. There's a slight risk of lower respiratory tract infections. The drug, by virtue of its mechanism of action, causes lymphopenia, and there are some possible associations with cutaneous malignancies, in particular basal cell carcinoma. Now, our next drug, the one that was approved only a few months ago in October, Teriflunomide, is a next-generation version of another medication called Laquinimod, which has been used in treatment of rheumatoid arthritis for many years. This drug has an effect on resting lymphocytes, on activated or stimulating proliferating lymphocytes, and reduces the number of these activated lymphocytes. And it does so, we think, through inhibiting pyrimidine synthesis. The medication interacts with dihydroerotite dehydrogenase, a key enzyme required for de novo pyrimidine synthesis. And in the case of the pro-inflammatory cells that have been stimulated that are rapidly dividing, there is an increased demand for pyrimidine nucleotides. And so by interrupting this pathway with teriflunomide, we decrease the synthesis of pyrimidine, and as a consequence, we have a decreased population of actively dividing lymphocytes. This is the proposed mechanism of action for this medication. Now, we've had now 2 phase 3 trials that have completed. You can see the results for the TEMSO study here, but just last week we heard about the results for the TOWER study as well that was presented at the American Academy of Neurology. Both trials showed almost identical clinical endpoints. I would just mention here we've seen a reduction in the annualized relapse rate by about 30%, reduction in 12-week sustained change disability measures by about 30%. Very, very similar numbers to what has been previously reported for the interferon trials, for example. And a head-to-head comparative study of teriflunomide to thrice-weekly interferon beta-1a, data not presented on this slide, showed really no difference between those 2 compounds. You can see effects on MRI in terms of burden of disease, in terms of T2 burden of disease, contrast enhancement, and the number of unique lesions identified on the scan. What we found, and the data here is presented for 14 milligram placebo, what we found out last week for the TOWER study is that the 14 milligram dose versus the 7 milligram dose, and both are US FDA approved, really did seem to be better in the TOWER study. So our recommendations based on the TOWER and TEMSO study is to begin with the 14 milligram dose and to use the 7 milligram dose in patients who develop adverse events at the higher dose. Now, some of those adverse events are common. Patients can develop nausea and diarrhea. There can be some dyspepsia. Liver function abnormalities are very close to that seen with placebo, yet the FDA decided that patients who are treated with teriflunomide should receive monthly liver function monitoring based on the parent compound leflunomide's label. When you look at the liver function abnormalities in the trials, one really doesn't see a big difference between teriflunomide and placebo. Nevertheless, additional caution is required, and monthly blood monitoring for 6 months is indicated. We also require our patients to undergo a TB skin test as well as to have a baseline CBC just in the event that the patients have some pre-existing condition that will alter their white blood cell counts. Alopecia can occur in about 10% of patients. It is reversible with drug discontinuation, and you can see a variety of other adverse events are reported on this slide that occur at relatively low percentages. Now, the most recent entry into the MS space is dimethyl fumarate, indicated here by BG12. This drug was just approved 2 days ago by the US FDA. This is an interesting compound. Fumaric acid esters are Krebs cycle metabolites. Work on fumaric acid esters really came out of the psoriasis literature, and various versions of this type of molecule have been used in treatment of cutaneous conditions going really all the way back to the 17th century. But in Germany, dimethyl fumarate has been approved and is used for treatment of psoriasis for over 20 years. Now, we don't really understand the full mechanisms of action of this small molecule, but it is possible that part of its effect in MS is through activation of the NRF2 pathway, a pathway whose signaling triggers induction of a number of antioxidative enzymes. So we think that part of the effect of dimethyl fumarate in MS may be through antioxidation, an effect that is intriguing and might be applicable for other neurodegenerative diseases as well. Now, the data for dimethyl fumarate is supported by trials that are the DEFINE and CONFIRM trial. These were large trials with quite a few patients treated. You can see some of the numbers here. And you can see the annualized relapse rate with 240 milligram twice daily dimethyl fumarate is reduced by about 50%. And in the DEFINE trial, there was about a 30% reduction in the progression of disability, as well as very potent effects in terms of MRI activity. Now, what are the side effects of this medication? Well, it can cause some flushing. This is most prominent in the first month of treatment, an effect which is largely abrogated by co-treatment with aspirin. The drug can cause some headaches, but most importantly for our patients, is likely to cause some GI upset. And that GI upset may be present for about 6 months. And this can include abdominal pain, nausea, even vomiting and diarrhea, and will probably be the leading cause of dosage discontinuations in our patient population. There may be also some mild increase in liver function abnormalities and the potential for lowering white blood cell counts. And for this reason, the US FDA is recommending that all patients receive a complete blood cell count at baseline and then again annually with treatment with dimethyl fumarate. This drug is also pregnancy class C. Now, one of the medications, which is an oral therapy currently under development for treatment in MS, is a medication called Laquinimod. And in a rat EAE model, there were a number of interesting effects of Laquinimod, shifting the TH bias from TH1 to TH2, inducing a number of cytokines involved in regulatory function, including IL-4 and IL-10 and TGF-beta, and also inhibiting infiltration of macrophages and CD4 positive cells into the spinal cord, and may even have some neuroprotective effects through upregulation of brain-derived neurotrophic factors. So an interesting compound. It went through its development in the US with 2 very large phase 3 trials. The results here are summarized. These are called the Bravo and Allegro trial. And unfortunately, this drug, although was effective, had only modest impact in terms of relapses. There was a reduction by about 23% with respect to the annualized relapse rate. But with respect to disability progression, we saw reductions of about 37% with respect to disability. Similarly, interestingly, the radiographic correlate of disability is brain volume loss, and there was statistically significant impacts on brain volume loss with this medication in both of these studies. So the drugs seem to have a disproportionate effect in terms of disability and brain volume loss, less of an effect on markers of inflammation such as contrast-enhancing lesions or new T2 lesions or relapses. So what's going on with this drug now is that it's going into another phase 3 trial where an even higher dose of the medication is being used. The 0.6 milligram dose was used in both of these studies, and a phase 3 trial with 1.2 milligrams is now being investigated to see if we can get an even higher anti-inflammatory effect. Certainly the impact with respect to disability and brain volume is intriguing and suggests that maybe this medication would be useful in the type of patients who don't even have relapses, perhaps in secondary progressive or primary progressive patients, or perhaps in adjuvant with other medications to be used in combination. So there are still some unanswered questions, and I think this product has not really been fully investigated yet and has certainly got some intriguing properties. So in terms of adverse events, it was actually pretty mild. There was a little bit of a bump in terms of LFTs. Some patients experienced headaches and arthralgias, but in general, the medication had a very good side effect profile. This was an issue because its parent compound, Laquinimod, had been associated with systemic pro-inflammatory effects, including pericarditis and myocardial infarction, and none of those things have been observed with Laquinimod. So the development of this medication really resulted in improvement in its toxicity profile. I'm going to talk about a monoclonal antibody now that we anticipate is going to be US FDA approved later on this year. This is Alemtuzumab. Alemtuzumab is a very potent anti-inflammatory drug. My colleague, Dr. Fox, has done some of the key work in development of this compound, and it is a humanized monoclonal antibody against CD52. CD52 is expressed on the majority of lymphocytes and B cells. And what happens when you treat patients with alemtuzumab, it's administered by IV infusion. The first set of infusions are done daily over a 5-day period of time. Is you see massive depletion of lymphocytes, and you see a depletion of T cells and B cells through apoptosis and antibody-dependent complemented lysis. And so you drop out 95% of your T and B cells, and then gradually over time these cells repopulate. And the thought is it's the repopulation of these lymphocytes that induces a type of lymphocyte that is less anti-inflammatory for the central nervous system. It's kind of like you take the immune system, you shake it up, and sort of try to reprogram it afterwards. There is a series of trials that were done, first a phase 2 trial versus thrice-weekly interferon beta-1a, and then 2 large phase 3 clinical trials versus thrice-weekly interferon beta-1a. This product was not tested versus placebo, so it set the bar very, very high with respect to efficacy. And all of these studies were superiority study designs. That meant that if the trials were positive, the drug had to be statistically significantly better than thrice-weekly interferon beta-1a. And here are the results. You can see the impact in terms of the annualized relapse rate significantly reducing the annualized relapse rate by about 50% relative to interferon beta-1a, and also reducing 6-month sustained change disability, statistically significantly reduction by about 40% versus interferon beta-1a. Now, in terms of adverse events, although the efficacy is really undisputed here, there are some problems associated with this medication. And unfortunately, in the same way that one reduces autoimmunity against the central nervous system, one also seems to increase autoimmunity against the thyroid. About 20% of patients who are treated with alemtuzumab will develop de novo autoimmune thyroid disease. A few patients have even developed a type of autoimmune nephropathy called Good-Pasteur's syndrome. And some patients, at least one patient, has required a kidney transplant because of this. ITP can also occur, and this is thrombocytopenia, which is induced by this medication, occurs in a few percentage of patients and can be monitored for, and when it's caught early, can be treated. Unfortunately, one of the patients in the phase 2 trial was not adequately monitored and developed a cerebral hemorrhage and succumbed to the cerebral hemorrhage. Infections can occur. You can have herpes virus reactivation occurring, and there may be associations with possible malignancies, including Burkitt's lymphoma. So there is an adverse event profile associated with this medication, which is probably going to limit its application in general clinical practice to patients who either have highly active disease or as a rescue therapy for patients who haven't responded well to other, perhaps less difficult to administer treatments. Now, one of the MS models that we have really enjoyed at UCSF is the B-cell model for MS. We've been investigating B-cell therapies for quite some time, as well as the role of B-cells in multiple sclerosis. And as Dr. Fox had alluded to earlier, for many years, B-cells were thought to have really no role in multiple sclerosis based on work done in the EAE model, in which animals could have developed EAE without any B cells whatsoever. So in that RAG1 deficient type of mouse, one could still get EAE. And for years we thought that that meant that MS was a T-cell mediated disease and ignored the role of B cells. We now understand that B cells have a vital role in MS. not only probably through antibody production, but also through antigen presentation. And strategies to deplete B cells have been very successful. And anti-CD20 is one of the molecules on the surface of B cells, and several monoclonal antibodies listed here, rituximab, ofatumumab, and ocrelizumab, all are capable of depleting anti-CD20. And as a consequence of this, we think that those depleted B cells are now no longer able to communicate with their T cell counterparts. And one of the things that we've observed in clinical trials is a significant reduction in the number of GAD-enhancing lesions, as well as a reduction in relapses in 2 phase 2 studies. Now there are 2 large phase 3 clinical trials going on with the next generation version of rituximab, a medication called ocrelizumab, and we will see those results in about 2.5 years. Now, some adverse events do occur with B-cell depletion. There certainly can be infusion-related reactions. Those seem to occur more commonly with rituximab than with the humanized version, ocrelizumab. There may be an association with PML, although that association, if it is there, seems to be relatively rare. The overall risk seems to be about 1 in 40,000 and is confounded in all cases by co-treatment with other immune suppressants or by the presence of other conditions such as HIV that can predispose to PML. And of course, rituximab has been FDA approved for treatment in not only rheumatoid arthritis, but of course non-Hodgkin's lymphoma, and it's in those patient groups that PML has been identified. So I'm going to turn our attention now to some of the primary endpoints for MS clinical trials. We've really focused on several endpoints here during this morning's presentation: annualized relapse rate, the impact on MS-related disability, as well as the impact on MRI-related disease activity. But some of the goals of the Multiple Sclerosis Outcomes Assessment Consortium are to develop new standards for assessing outcomes in clinical trials of MS therapies, and also to qualify a new clinician-reported outcome measure of disability as a primary endpoint for future MS trials. One of the frustrating aspects of MS to try and show an impact on disability is that we so far are stuck using the expanded disability status scale of Kurtzke, a tricky scale. It's somewhat difficult to use in clinical practice and associated with not much movement, especially early on in the course of the disease. The sponsors for these studies are the Critical Path Institute, the National MS Society, and the coalition partners with industry, academia, patient representatives, the regulatory agencies, and the National MS Society. So hopefully we'll have more to report next time we convene in this regard. But I want to turn our attention now to some of the symptomatic management in MS. There's now treatment for fatigue with armodafinil, especially fatigue associated with excessive daytime somnolence. Poor ambulation or slow ambulation can be treated with dalfampridine, and pseudobulbar effect can be treated with dextromethorphan quinidine. MS-related pain has been shown to be affected by duloxetine in one clinical trial, and another clinical trial with dextromethorphan quinidine is currently underway. Multiple therapies are available for treatment of spasticity, as are therapies for depression and other psychological problems. Urinary dysfunction also has treatments, especially for the spastic bladder and for patients who have difficulty with voiding due to sphincter dyssynergia. Sexual dysfunction can also be treated, and unfortunately to date we really have no therapies in MS that are effective for cognitive impairment. So when we're thinking about our therapeutic decisions, we have to weigh risks and benefits, as we always do. In terms of benefits, there's the meaningful impact, the effect on disability progression, and convenience for our patients. In terms of the risks, there's short-term safety risks for our drugs, as well as long-term safety risks, convenience, and cost. So when we're making our treatment decisions, we, of course, are weighing all these things together. We have to think about safety, about tolerability, convenience for the patients, need for monitoring, which may be more burdensome for some treatments than for others. Issues with respect to pregnancy. Of course, MS, 70% of our patients are women, and many of them are in childbearing years. Cost associated with these drugs has gone up and up and up. Initially, these medications ran about $8,000 per year and now are in excess of $60,000 per year in terms of their average wholesale price. Patient's preference is important as well as physician experience. A response to therapy, of course, is something that we have to develop better tools for measuring. Mechanism of action factors in, and of course all of this requires us to, whenever possible, adhere to best evidence-based practices. So I'm just going to conclude this one section and just say, in wrapping things up, this is a fantastic time for MS. We've got multiple therapies that actually modify the course of the disease. This is a very important therapeutic advance in neurology and is one of the actual great advances in terms of modern medicine. That and our ability to combat HIV probably are two of the most significant developments we've had in the last 20 years. We've got multiple treatments which are in late-stage pipeline for development in MS. And, of course, we always have to weigh efficacy and safety issues in balance.